You're listening to Who Said, a cardiology board review series. No fluff, just facts.
Welcome to part 2 on our discussion on LVADs. In the prior episode, we explored patient selection for LVAD, types of LVAD, LVAD components, LVAD physiology and troubleshooting, including the concepts of speed, flow, power, pulsatility index, and pulsatility index events, and we went over LVAD complications. In this second part, we'll focus on imaging aspects of LVAD. We'll talk about pre-LVAD echo assessment, the post-LVAD echo assessment, and the very important ramp study. Let's start with the pre-LVAD echo assessment. Pre-LVAD implantation, you need to look for the following on echo. Overly small LV cavity, for example, an infiltrative cardiomyopathies, because if you try to put an LV in that small cavity, it is just going to get obstructed and be disastrous. If there is LV thrombus, LV apical aneurysm, or VSD, that is not ideal for LVAD implantation. RV function, make sure that it is healthy and decide whether you need to give biventricular support instead of just a left ventricular assist device. Make sure there's no left atrial appendage thrombus. Look for a PFO or ASD, because if that exists, that needs to be repaired at the time of the surgery. And look for regurgitation. If you have anything that's moderate or above, moderate AR, MS, MR, or moderate TR, or above, that will affect the hemodynamics of the LVAD. For the aorta, identify any mobile masses, thrombus, or plaque. There are absolute and relative echo contraindications to LVAD implant. Smaller cavity, LV cavity, defined as a left ventricular end diastolic diameter less than 6.3 centimeters, is associated with increased 30-day after LVAD implantation, but it is not an absolute contraindication to LVAD implantation. Intracardiac thrombus is not an absolute contraindication to LVAD implantation, but it may increase the risk of stroke during the LV cannulation portion of the procedure. Acute endocarditis or any other active infection is an absolute contraindication to device implantation because of the risk of bacterial seeding of a newly implanted LVAD. Mitral regurgitation is expected to improve after LVAD implantation and thus is not considered a contraindication to LVAD implantation. Defects that must be corrected at the time of LVAD implantation are as follows. Moderate or severe mitral stenosis can prevent adequate LVAD cannula inflow because the blood has to get through the mitral stenosis from the LA to the LV before it can reach the LVAD. So, moderate or severe MS must be corrected before LVAD implantation. Moderate or severe AR enables a blind loop of flow in which blood enters into the LVAD from the LV, is pumped into the ascending aorta, but then flows back into the LV through the aortic valve, and thus this must be addressed prior to LVAD implantation. Surgical options for moderate or severe native valve aortic regurgitation are replacement with a bioprosthesis, completely oversewing the valve by suturing along all coaptation zones to seal it shut, or performing a central coaptation or park stitch. But it is important to note that there will be minimal or zero forward flow in the event of an LVAD failure if you sew the aortic valve shut, so that's a dangerous option as well. Mechanical aortic valve replacement is a bad idea because of the prohibitively high risk of mechanical valve thrombus formation, which would complicate LVAD function. In contrast, aortic stenosis of any severity can be left totally alone without affecting LVAD function because the LVAD completely bypasses the native LV outflow tract, and aortic stenosis will not create a blind loop of flow, unlike aortic regurgitation that's severe, which creates a blind loop of blood that enters the LVAD from the LV, is pumped into the ascending aorta, but then flows back into the LV into the regurgitation aortic valve. Mitral regurgitation will improve after initiation of LVAD because of reduced LV size, reduced filling pressures, and improved coaptation of the mitral valve leaflets after LVAD implantation. Therefore, MR of any degree, even severe, is acceptable in LVAD candidates. Although PFO is naturally found in 25% of the population, in patients who are getting an LVAD implant, the PFO or any ASD should be closed at the time of device implantation due to the risk of hypoxemia and paradoxical embolization if it were to be left open. Now let's move on from pre to post-LVAD echo assessment. On echo post-LVAD implantation, you need to look for the following. In the early post-op period, look for pericardial effusion, RV failure, or LV failure due to inadequate unloading. In terms of long-term complications, look for inadequate LV filling due to RV failure or excessive pump speed or cannula malposition, that's suction. Look for intracardiac thrombus, unmasked aortic regurgitation, or atrial level right to left shift. Right ventricular failure following LVAD implantation occurs in 20% of patients, and that carries a high morbidity and mortality. After LVAD implantation, the right ventricle begins to receive a significantly increased stroke volume due to the much more efficient cardiac output from the LV to the rest of the body. In some cases, the right ventricle cannot appropriately accommodate this sudden increase in volume and fails. Echo findings of RV failure post-LVAD are RV enlargement, reduced RV function on traditional measures, interventricular septal position shifted toward the LV, dilated IVC, and worsening tricuspid regurgitation and elevated pulmonary pressure. During suction events, the LVAD decompresses the LV chamber to an abnormally small size, resulting in a right to left interventricular septal shift. If you see LVAD suckdown events, think about what is causing it. Could be device related, such as inflow cannula obstruction, could be structural, such as new or worsening RV failure, or it could be reduced preload, such as hypovolemia, GI bleed, or tamponade. Pump thrombosis will manifest itself as hemolysis, hemoglobinuria, elevated lactate dehydrogenase, elevated bilirubin, and on echo, there will be signs of reduced LV unloading compared with the previous echo. You will have increased LVIDd, increased MR, septal shift toward the right ventricle due to increased left ventricular volume, and increased aortic valve opening duration or frequency compared to the prior echo because the blood cannot go through the LVAD efficiently, so it goes through the aortic valve through the left ventricular outflow tract, causing you to have increased aortic valve opening duration or frequency because it's taking the path of least resistance. If the pump thrombosis is impeller, then despite increasing LVAD speed, there will be no change in the outflow cannula velocity. There will also be no change in the LVIDd and the amount of aortic valve opening despite your increasing the LVAD speed. If you have a surprisingly high estimated LVAD flow but normal power, consider the possibility of moderate to severe aortic regurgitation. Aortic regurgitant volume can lead to increased LV preload, which may result in increased native LVOT output and aortic valve opening, with intermittent aortic regurgitation on color Doppler. Alternatively, aortic regurgitation may be continuous if the contractile force is not sufficient to interrupt the regurgitant flow during systole. Aortic regurgitation is an issue after LVAD placement. 25 to 50% of post-LVAD patients will develop moderate or higher AR within 1 year of LVAD implantation. In an LVAD patient who has developed moderate or severe AR, Doppler flow across the inflow cannula and outflow graph will be normal or increased due to the aorta to LV to LVAD blind loop. To assess for aortic regurgitation in an LVAD patient, assess the aortic valve opening over 5 to 6 cycles of parasternal short axis and M mode. Use color flow imaging to estimate the regurgitant orifice size. You can use color Doppler on 2D parasternal short axis zoomed in view of the aortic valve and also color Doppler M mode. You can no longer use pressure gradient methods between the LV and aorta. AR pressure halftime and pulse Doppler of the ascending aorta are totally invalid in the setting of LVAD due to the outflow graph flow in the ascending aorta. You can still use aortic regurgitation duration, vena contracta width, or LVOT jet height if you want. In terms of interrogating the LVAD inflow cannula, use the PW Doppler to avoid contamination from mitral inflow or from aortic regurgitation. The flow should be towards the transducer such that your PW signal will be upward. The inflow cannula velocity should be less than 1.5 meters per second. The systolic velocity at the time of the T wave should be higher than the diastolic velocity. The higher the S to D velocity ratio, the better the LV function. Systole will have LVAD flow plus native LV flow. Diastole will have LVAD flow without native LV flow. So this should look like a fence with a jagged top and flat horizontal intervals between the jagged peaks. If the peak during diastole is higher than during systole, then something is inaccurate, probably contamination of signal. On a HeartMate 3, which uses the rotor speed to drop every 2 seconds to reduce the risk of thrombus formation, there will be a gap in the signal every 2 seconds. For calculating cardiac output on the LVAD, you can still use the LV stroke volume formula, except you have to apply it to the RV outflow tract using RV outflow tract diameter, RVOT VTI, and heart rate using the R interval on ECG. This assumes that there is no significant AR. This assumes that the cardiac output consists of the output from the LVAD plus a contribution of the LV, both of which are captured by the RVOT equation. Interrogating the LVAD outflow cannula. So just now we talked about interrogating the LV inflow cannula. Now we're going to talk about interrogating the LV assist device outflow cannula. The flow should be away from the transducer such that your PW signal will be downward. This time is different. When we interrogated the LV inflow cannula, the flow was towards the transducer and the PW signal was upward. So in LV outflow cannula interrogation, the systolic velocity at the time of the T wave should be higher than the diastolic velocity, just like when you interrogated the LVAD inflow cannula. The higher the S to D velocity ratio, the better the LV function. The peak systolic velocity varies by device. It should generally approach 2 meters per second. In a non-pulsatile LVAD patient, blood pressure is measured by using a handheld audible Doppler applied to the brachial or radial artery. The cuff pressure at which a Doppler signal is obtained is the map. How do you assess size and function of the left ventricle post-LVAD? The LVIDd from the 2D parasol long axis is the most reproducible measure of LV size after LVAD implantation. Although LV volumes determined by Simpson's biplane or single plane method normally reflects the LV size more accurately than do linear measurements, the LV size by volume assessment is difficult to obtain in an LVAD because of apical shadowing and dropout due to the inflow cannula. LV systolic function is difficult to evaluate in the setting of continuous LVAD unloading. When native LV recovery is suspected, LVEF assessment is attempted by Simpson's biplane or the single plane method. It is safe to assume that any LVAD patient has markedly abnormal baseline diastolic dysfunction. Many of the standard LV diastolic function parameters can be measured after LVAD implantation, but they have not been specifically validated in this population. Now that we've understood post-LVAD echo assessment, let's focus on the ramp studies. What is a ramp study? An LVAD ramp study is performed to optimize the function of an LVAD in patients who are experiencing pulsatility index events, low flow, or heart failure signs despite LVAD support. A ramp study systematically adjusts the LVAD speed while simultaneously monitoring hemodynamic parameters and echocardiographic findings to identify the optimal speed settings that achieve better left ventricular unloading without causing complications like suction events or right ventricular dysfunction. RAMP does not stand for a specific acronym, as far as I know, but refers to the gradual systemic ramping up or ramping down of the LVAD speed to optimize function. When performing an LVAD speed change echo, first you do a routine comprehensive TTE at the baseline speed setting, then at each incremental level of LVAD speed, you measure the LVID, the interventricular septal position, the aortic valve opening frequency or duration, and the TR and/or MR severity. You are striving to get a combination of settings that adequately unloads the left ventricle, doesn't overload the right ventricle, and maintains cardiac output. As you increase the speed in revolutions per minute, what is the effect on LV outflow? You unload the LV, decreasing the LV pressure. You increase the pulsatility of the LVAD outflow. You decrease the native mitral regurgitation volume, and you offload the right ventricle. The native aortic valve opening and closing becomes more intermittent and eventually doesn't open or close. That's what happens if you increase the speed in revolutions per minute and their effect on LV outflow. Now, as you increase the speed in revolutions per minute, what is the effect on LV filling? You make LV filling easier, causing a higher E to A ratio. You may drain the fluid out of the LV too quickly, causing obstruction of flow into the LVAD inflow cannula, preventing it from doing its job. You may worsen TR. Speed change echo testing is only done if the patient has been receiving therapeutic doses of anticoagulation. Risks of performing a speed change echo test include embolic events from sudden aortic valve opening, which is return to pulsatile flow in the event of undiagnosed aortic root thrombus, and potential liberation of peripheral or internal pump thrombi, particularly at lower pump speeds. Reasons to stop a speed change echo test or ramp test are completion of a test, a suction event which can occur at higher speeds, patient symptoms that are related to hyperperfusion or hypotension, such as palpitations, dizziness, headache, chest pain, or shortness of breath, hypertension defined as a MAP exceeding 100, or reversal of the inflow or outflow cannula. These are reasons to stop a ramp test. So we have talked about pre-LVAD echo assessment, post-LVAD echo assessment, and ramp study. That's it for part 2 of LVAD.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rvu.com/meded.